Hi, I'm Dr Cronin, Specialist Plastic Surgeon at the Coastal Clinic, and today I'll be talking about breast augmentation surgery. So the ideal candidate for a breast augmentation procedure is someone who's happy with the shape of their breast and the position of their breast, but is keen on increasing the volume of their breast. Ideally, the patient will be in good health with no other medical conditions and be a non-smoker. Often patients will present to discuss breast augmentation surgery with ideas on what size implant they would like, and that's often based on other women that they know that may have had a breast augmentation and achieved the desired outcome for that patient with a specific size. It's important to remember that in order to get the same outcome for a number of different patients, a number of different implants would need to be used because everyone's different with the amount of breast tissue that they already have and with the height and width of their breast plate. So during a consultation, my role in assisting selecting the right implant for that patient is firstly to get an idea of what their desired outcome goals would be with regards to projection or cup size or shape, and then to make an assessment of what breast volume they already have, and then of course to measure the width of their breastplate and the height of their breastplate, because that's the most important determinant of what the final volume of a breast implant is, and then of course calculate the amount of projection of that implant that they would require. And sometimes there'll be limitations on how large an implant can be used because of the amount of skin that the patient has in order to get around the outside of that implant. And in other cases it may be that there's a minimum volume of implant that the patient will need because they have a relative excess of skin to the amount of breast tissue that they already have. So the other question that gets brought up regularly is whether a patient is a candidate for a round implant or a teardrop or anatomical shaped implant. And there's a perception that in general having a round implant will always give a patient a fake or enhanced look, whereas using a teardrop shaped implant or an anatomical shaped implant will give them a more natural look. And in reality it's a little bit more complex than that. Obviously there are different types and different projections of round implants, and so using a more projected round implant will always give a more enhanced look than using a less projected round implant. In fact, the most important indication for whether or not a patient can have a round implant is to do with the height and the width of the breast plate and the position of the nipple. So to fit a round implant, obviously a breast needs to be as wide as it is tall, and the nipple needs to be in the middle. Now someone who's very, very tall and lean in stature may have a breastplate that's relatively taller than it is wide, and so obviously a round implant with a round base won't necessarily fit that person's breast plate. What I see more commonly is in patients that have maybe had a couple of children and breastfed and then stopped breastfeeding and noticed a degree of ptosis, that although their breast plate is the same width as it is height, their nipple's no longer in the middle of the breast. And so obviously using a round implant, it means that the nipple position would be placed on the underside of the breast and the nipple would be pointing towards the ground. And so for those patients, it may be that they're a good candidate for a teardrop shaped implant, because even if their nipple is in the lower third of the breast plate, it'll still be pointing forwards in the correct direction. Another common question is about which plane the breast implant is placed in, and historically there were two planes, either in front of the muscle or entirely underneath the muscle, and each had their advantages and disadvantages. Those techniques have evolved over the years, and these days most surgeons would do what's called a dual plane procedure, where the upper part of the implant is covered by the pectoralis major muscle, and that means that the risk of palpability and rippling and being able to see the implant through the skin, particularly in the upper half of the implant, is reduced, but the lower part of the implant is still flush up against the breast tissue and creates that natural lower crisp breast contour. Historically, there are a few different incision types for breast augmentation as well. 20, 30 years ago, it was very common to have a periareolar or infraareolar around or underneath the nipple incision for the placement of the implant, because it avoided an obvious scar. And the difficulty with that incision choice is that the dissection down underneath the muscle has to go all the way through the breast tissue as well. So all of that breast tissue is interrupted and can form scarring that tethers to the nipple. So I've seen many patients over the years that are happy with their breast implants and the placement of the breast implants, but as their breast has continued to drop, the nipple has been pulled up towards the implant, and it's a difficult issue to fix. My own preference and the incision type that most surgeons would perform these days is the incision through the IMF, because it allows you to dissect behind all of the natural breast tissue and not interrupt any of that breast tissue. It's less likely to cause problems with breastfeeding and with scarring through the breast tissue, and it allows you to neatly dissect above and below the pec muscle to create that dual plane that we use. We've also realised over the years that most of the complications that occur with breast implants are related to the rates of infection of the breast implants, or even subclinical infection of the breast implants upon placement. And the inframammary fold incision has been shown to have much lower rates of secondary infection of the breast implants than the infraareolar incision or the armpit incision that was quite popular about 10 to 15 years ago. So a breast augmentation procedure is performed as a day procedure, typically. Patients can expect to wake up in recovery in their post-operative garments. They'll be discharged home the same day with a course of post-operative antibiotics and some post-operative analgesia. Everyone's recovery and downtime is slightly different, and that's the case with any surgical procedure. But the vast majority of patients will report that they were off their pain medications after about 3 or 4 days. With regards to getting back to work and being able to drive, essentially patients are allowed to drive when they no longer feel that they would have difficulty if they needed to stop the car quickly by slamming on the brakes, and if they were worried about pain that would cause to the chest. Depending on what people do for work, most patients can expect to be back at work within a week or two post-operatively. With exercise, which is a common question as well, I tell patients that they're not to do anything that essentially makes them sweat for the first few weeks afterwards, and that's more to do with making sure that the incisions are kept clean and dry, and with going back to the gym and lifting weights or doing high intensity interval training. I tell all of my patients that they won't be able to go back to that for about 6 to 8 weeks, depending on the type of implant that they have, because of the potential risk of moving the placement of the implant by contracting the pectoral muscles. A common question for breast augmentation patients is what follow-up and post-operative breast care they require now that they have breast implants in. And often patients will say, oh, I've been reading around and it's recommended that I have my implants changed over every 10 years. Now, I think most women that have breast augmentation surgery, or historically have had breast augmentation surgery, may have then had other life events like becoming pregnant, having children, breastfeeding, putting on weight, losing weight, and often those patients will present back for revisionary surgery. The implant is still exactly where it was and there's been no problem with the implant per se, but their own body has changed and their breasts have changed and it's now affected the breast aesthetic. Obviously, implants are not designed to be lifetime devices like any implantable device. They do wear down over time, and there is the risk of implant-based complications such as rupture or capsular contracture, which is where the three-dimensional scar tissue that your body forms around a breast implant or any other foreign body begins to contract and can start to deform the implant. Now, I think if we looked at women that had had breast augmentation surgery over the last 30 or 40 years, if you were to find out the average length of time from when they had their primary procedure to when they presented back for consideration of some kind of revision, be it from an implant-based problem or just changes in their own body. If you averaged all of that, it would come down to around 10 years, which I think is where that 10-year kind of revision comes from. But essentially, if there's no problem with the implant, if there's no signs of capsular contracture such as pain or a sort of gradually hardening implant or a change in its position, if you're not noticing any lumps around the implant or in the axilla or anything else that might increase your suspicion for the chance of rupture, then there's no maximum duration of time that an implant can be in place. And certainly I've seen patients that have had implants in for 30 years that have never had an issue with them, and they've come to see me to say, well, I think I just need to have them removed because I'm supposed to have them swapped over after every 10 years. And obviously that's not the case. The other question is with regards to routine breast screening for breast cancer. So historically, mammograms were the choice of investigation or imaging of the breast to check for breast cancer. For women that have breast implants in, still just maintain normal breast cancer screening as they would otherwise, but instead of opting for a mammogram, they may need to have an ultrasound as part of that process instead. And particularly women that were quite small-breasted, that had a large breast implant, and now the majority of their breast tissue is made up of the implant, it may be easier for them to continue to screen for breast cancer with ultrasound as opposed to mammograms. The answer is that the vast majority of women who have breast augmentation, particularly a simple primary breast augmentation through an inframammary fold incision, should expect that they should have no issues with breastfeeding. Some women that present for breast augmentation will be unhappy with the amount of volume that they have in their breast, but they may have noticed that they've also had some descent of the breast as well. So for women who have no descent of the breast, as we covered, they may be a candidate for a round implant if their nipple placement's in the middle of the breast mound. Women that have had a mild to moderate amount of breastosis or descent may be able to get away with an implantation only with a teardrop or anatomical implant, but there will also be women where the amount of breastosis or descent is such that they won't be able to have their nipple in the correct position with an implant alone, and those women would be a candidate for a combined augmentation to increase volume as well as a mastopexy in order to reshape the breast back into a natural shape and to return the nipple to its normal position. And that procedure can be performed as a single procedure. To discuss breast augmentation surgery with me, contact the Coastal Clinic, and I look forward to speaking to you soon.